Stay tuned for the next report.
Pathway is a series of trials conducted by the British Hypertension Society investigating the treatment of hypertension. In Pathway 2, 314 well-characterised resistant hypertensive patients were randomised to receive, in a sequential manner, either spironolactone, an alpha blocker, a beta blocker, or a placebo. Every patient took every drug for 12 weeks.
Saw that the best drug for most patients, in fact almost every patient, was spironolactone. Low dose, 25-50 milligrams a day, vastly superior to placebo and highly significantly superior to the other blood pressure lowering treatments.
In Pathway 3, 440 obese hypertensive patients who were not receiving a diuretic were randomised to have either amiloride, 10 milligrams alone, hydrochlorothiazide alone, 25 milligrams, or a combination of both at half dose.
The summary of the study is that potassium-sparing diuretic amiloride is as effective at lowering blood pressure as hydrochlorothiazide, but has the advantage of preventing any glucose intolerance. And when the two drugs are used together, we have a win-win where all the benefits of the two drugs are amplified in lowering blood pressure and their undesirable effects are cancelled out.
In London, Alberico Catapano, current president of the European Atherosclerosis Society, summarised the latest advances in LDL management.
We have witnessed really a breakthrough discovery in the recent year in the area of LDL lowering. We now have a full armamentarium of drugs, statins, inhibitors of cholesterol absorption, and PCSK9 inhibitors that will allow us to be very flexible in the therapy and very, very effective. The main take-home message is now there are no excuses not to reach the target, the goal for therapy that we have addressed in the guidelines, the common guidelines between European Atherosclerosis Society and European Society of Cardiologists. I know those goals are demanding. 70 milligram per deciliter is not easy to reach, 1.8 millimole. However, now the tools are there, and especially in very high-risk patients, patients with familial hypercholesterolemia, no excuses anymore. Detect the patient and treat them.
So, resistant hypertension, let's start with that, Brian. I mean, you were the lead investigator for Pathway 2, and there's been a lot of concern about how we manage, how we identify what is resistant hypertension, and do we have some novel approaches to define this and to treat it?
So we looked at a population of patients who have been well defined now by the European guidelines. They have to be on 3 drugs, RAS blocker, CCB, plus a diuretic, blood pressure still not controlled. We were quite rigorous in making sure that their clinic blood pressure and their out-of-office blood pressure was not controlled. And also we looked at a variety of ways of assessing treatment adherence before the patients went into the trial. You know, it's remarkable that after 50 years, we still haven't seen a trial comparing different drugs for the treatment of resistant hypertension. So we tested spironolactone because there has been some evidence from small studies against placebo and observational trials that this might be a good drug, but we didn't know it was the best drug. And we went against a beta blocker and an alpha blocker, so we could block the sympathetic nervous system and also block renin with a beta blocker, just to see whether spironolactone came out on top, and it did. I mean, it was by far the best drug. It controlled blood pressure in the most patients. And at the end of the study, there was hardly anybody that we didn't get controlled or almost controlled with these 3 different approaches, but always spironolactone was superior.
So this has said something really interesting, that actually what we thought of as resistant hypertension, where we were told the arteries were fixed, is maybe not right. And it's a much smaller proportion than we thought.
Yes, I think maybe the definition of resistant hypertension needs to be revisited, because I think personally, now that we know that spironolactone is so effective in many of these patients, it really should be defined as patients who are not responding to treatment with the 3 drugs that we recommended previously, plus spironolactone. And interesting, getting to your point, Keith, if we look at how many patients were left at the end of that study who would have met a criteria for randomization, for example, into a renal denervation study, where you had to have stage 2 hypertension, 160 in the clinic systolic, we would have only had 15 patients left.
Right. So this brings up a really interesting point, Marco, that the trials of renal denervation were innovative and exciting, but they didn't show an impact greater than optimal medical therapy. And maybe that was because the patients weren't actually getting and receiving in part, or is it in part to do with the technique? What do you think?
I think renal denervation has two issues currently.
Yeah.
Number one, obviously, it didn't work in the randomized control trial. So we have to go back and see, was the application way, where the device is wrong, where the patient not the right one. So we have to go back and see, understand more about the mechanism. And number two, as just said, the population of the so-called resistant hypertension patient may shrink. There is one issue that the adherence to medical treatment may be very different, actually, in clinical practice, as compared to the clinical trial. So I would, a word of caution with respect to adherence, I think it's appropriate.
Can I just make a point about that, Keith? I mean, we actually brought all the patients into the clinic. We asked them to bring their medication. We asked them to take their medication in front of us, and then we measured their blood pressure over the last 6 months.
So we don't have the luxury of doing that
exactly.
sometimes in widespread clinical practice, and we must raise another issue that there's a concern in the medical community about side effects of spironolactone, in particular gynecomastia. This was seen less often in this Pathway 2 study.
So the main concern that's restricted a lot of people has been potassium, I think, and renal function. 2 points about this study. We saw an increase in potassium above 6, but below 6.5 in only 6 patients. And each of those was managed very easily. There was no issues. But we did not include people with an EGFR below 45. So we don't have any data on the safety below 45. So there are 2 key points. The gynecomastia we almost certainly wouldn't have seen in our trial because in my experience clinically where I have used spironolactone for hypertension, it's often a few months down the line, and our treatment cycles were for 12 weeks. That was enough to see potassium changes, but not enough to see gynecomastia.
And in some previous trials, there was a combination with digoxin as well that may have contributed to some of the gynecomastia.
Well, that's mainly in the heart failure trials, just to give the audience a perception of what kind of frequency of gynecomastia we see in hypertension. It's around 5 to 6% with spironolactone giving at the doses that we gave here, 25 to 50 milligrams a day.
Yeah. I'm going to turn to John now. In terms of the related issues in heart failure, but sodium's the bad guy. Is that right?
I was going to ask Brian that because obviously spironolactone and eplerenone are very effective treatments for heart failure. So Brian, was this about a diuretic effect or was this an anti-aldosterone effect? Because of course in heart failure we believe these drugs are mineralocorticoid receptor blockers, and that's how they bring about their benefits.
Great question. I think it's likely that many patients with resistant hypertension, particularly those that have very low renin levels at baseline, have probably got primary aldosteronism that we haven't been able to detect, and they would certainly respond well to spironolactone. It may also be simply because we're using another diuretic in addition to the thiazide they're already getting, blocking sodium reabsorption at 2 points in the nephron, and therefore getting more effective diuresis in this sodium retaining state. We need to do another study looking at whether either increasing the thiazide or using an alternative to spironolactone can replicate this effect.
Are your patients not running out on amiloride?
Yeah, that's it. We actually decided at the end of the trial, because not everybody finishes at the same time, and we had to keep the study blinded, that when they finish the study, we would run them out on 10 to 20 milligrams of amiloride. The advantage of that was to see whether the amiloride replicated the blood pressure lowering effect of the spironolactone in the blinded component of the trial. We haven't yet had a chance to look at that.
So that'll tease out the aldo versus sodium.
Yeah, it's not blinded, but it will give us an answer.
So let's come to a related issue, and that's to do with thiazide treatment in hypertension and people's concerns about hypokalemia and also the concerns about glucose intolerance. And we also have really interesting information from Pathway 3 in relation to this. Tell us about that.
Yeah, so my colleague Maurice Brown led Pathway 3. And it was interesting because, thiazide doses have been progressively reduced. And the assumption has been that we could do that without compromising the efficacy of thiazides. But we did it to try and reduce the frequency of hypokalemia and also impaired glucose tolerance. What we did in Pathway 3 was to say, well, the thiazide induction of diabetes is thought to be related to the drop in potassium. So why not try and see what happens with a potassium-sparing diuretic? These have traditionally been thought to be a weaker diuretic on blood pressure, but we used a much higher dose. So we used amiloride 10 to 20 milligrams a day compared to hydrochlorothiazide 25 to 50. 90+% of the patients were already on an ACE inhibitor or an ARB, so we could deal with the issue of tolerability of amiloride to see if they got hyperkalemia. And actually, amazingly, as expected, the diuretic increased the risk of diabetes, increased the 2-hour glucose, but the amiloride reduced it. And the combination of the two, at half the doses used in monotherapy, neutralized the effects on potassium and glucose and gave us more blood pressure lowering.
So Brian, you've clearly presented the findings from the study, but I want to turn to somebody else because clearly you were linked with the studies. Sure. I'm going to turn to Sanjay to talk about, in your view, what's the significance of these studies and also in relation to different populations around the world?
Well, I think for me, the thing that grabbed me the most was that these are old drugs changing paradigm with an excellent outcome. These are as cheap as chips, spironolactone and amiloride and thiazide diuretics. And this is important in the current financial climate. The other thing, of course, is that I'm concerned about the impact on ethnicity because 5% of the British population is black and 13% of the American population is black. And these are the individuals that more likely have resistant hypertension and impaired glucose tolerance and will probably benefit the most. But we mustn't just limit this to Europe and America. We've got to think about Africa and South America where these countries are developing and finances are scarce. So these drugs could be revolutionary.
So here are generic therapies that could be added to standard of care with widespread applicability. And so we think that that's really an important take-home from this Congress.
Absolutely.
May I ask a question?
Yeah, sure.
I would like, because I'm near sure that after this meeting, all over the world, the spironolactone will be widely used. So I would like to ask you one practical question, because the people will start, of course, in the population with GFR higher than 45. But if during the treatment, the renal function will be a little bit worse, what do you advise?
It's a very good point. We looked at renal function with all the interventions. An interesting thing is, everybody who has blood pressure lowering with resistant hypertension, whether it's a beta blocker, alpha blocker, or the spironolactone, had a reduction in GFR. And that is related to the reduction in renal perfusion pressure, which we know is almost certainly protective in the long run. So if it's a small reduction in GFR, 10% fall, and that stays stable and doesn't get worse, carry on with the treatment, because that is just a function of the blood pressure lowering. But the point you make is very important. You must measure potassium and renal function after initiating this treatment within a couple of weeks, and then, depending on whether there's a change or not, periodically thereafter, because we can't be complacent about the fact that we have an ACE inhibitor or an ARB and an aldosterone blocker on board, and we need to be careful to make sure we monitor these.
I mean, we've obviously got a lot of experience of that combination in heart failure, and everything you said's right, Brian. I mean, it's almost that a reduction in EGFR is a marker of the effect of the drug, an indicator of the patients who are likely to benefit, at least in heart failure. So,
and in diabetes too.
A modest reduction in EGFR is not something to be concerned about, not something to make you stop treatment.
Okay, so some really important messages from that. Let's now turn to lipids, because there's also been some important information about lipids, the management of hyperlipidemia in diabetics, and also how low one can and how low one should go with the advent of the PCSK9 inhibitors. So Sanjay, what should we make of all this?
Let's start with the IMPROVE-IT trial, whereby they looked specifically at the impact of the combination of simvastatin and ezetimibe on cardiovascular mortality, myocardial infarction and stroke in patients with diabetes versus people without diabetes. They managed to get the LDL down to less than 1.4, and they found that the absolute benefit in individuals with diabetes was 14% versus 2% in non-diabetics, suggesting that the diabetics did well. And this perception that low is good seems to be true. The other important thing, of course, is the PCSK9 inhibitors, which have now demonstrated that you can actually bring down the LDL to these levels in addition to statin therapy. In fact, if you add in PCSK9 inhibitors to statin therapy, you can bring down the LDL cholesterol by 50%, achieve targets in 80%, and this effect seems to be attenuated.
Even in heterozygous FHs?
Absolutely. and in high-risk cardiovascular patients. And these effects seem to be attenuated for up to 80 weeks.
So, and also an exciting study presented just in a poster here of an entirely different way, because the two PCSK9 inhibitors work in one way, but there's an interference RNA that can block with a single injection for 6 months, halving your LDL. Is this fantasy land? Is this?
Well, I'm an optimist, so I wouldn't say it's fancy land, but I think anything that manipulates genetics needs to be studied in a bit more detail before we can actually accept this type of therapy.
So studied in more detail, and I'm going to turn to you, Victoria, because, you know, the elegant imaging techniques that we have at the moment and some that are in development, how can these give us insights into atherogenesis and what's happening in plaque?
That's a very good question, because there are already studies showing in patients with acute coronary syndrome that they are starting with these new therapies that actually you reduce the LDL levels, but the changes in plaque burden, plaque composition is modest. So we need to know a little bit more how these drugs can also give us a reduction in plaque burden that will give later on the new events, cardiovascular events.
So you've got the whole array of imaging tools at your hands. Which ones are you going to choose?
I think that one of the most widely used currently is intravascular ultrasonography, but there are also near-infrared technologies and other technologies that give us also the temperature of the plaque and can give us a more idea on how vulnerable that plaque is and when is going to come the new cardiovascular event.
So I guess there's a watch this space about, you know, whether these profound changes in LDL may change some of the accumulation of lipid within the wall and within the plaque, but we need some studies to define that.
Exactly.
So, Janine, I'm going to turn to you. You know, we've made great progress in acute coronary disease, but what about the time after? Are we doing enough in lipid lowering?
For sure not. I can tell that we are not doing enough in secondary prevention, because if we are looking to the results of acute treatment of acute coronary syndromes, the results are good near all over the world, of the Europe. But when we are looking for 2 or 3 years long-term results, then we can see that we are not follow the secondary prevention indications. So that's the time and the hope that maybe injection 2 times per year, we hope is that, but it is a long story before us. But at the beginning, we have very simple thing to do. Just physical activity, stop smoking and so on, and also still use antiplatelet therapy after the intervention.
And so, you know, one of the take-homes from this has been that from EuroAspire, we learned that we're actually pretty ineffective in dealing with most of the patients that we should be treating, both for primary and secondary prevention. So there's scope to do a lot with what we have already.